Invitamos ahora a Seul Kai Park, que nos va a hablar del desarrollo y evaluación de modelos predictivos basados en datos de historia clínica electrónica. Ella es actualmente candidata a doctorado en la Facultad de Enfermería de la Universidad Nacional de Seúl. Tiene un máster en informática en enfermería. Su investigación se centra en la seguridad del paciente, minería de datos y sistemas de soporte de decisiones clínicas.
Hello everyone, my name is Silgi Park and I'm a nurse and a PhD candidate majoring in nursing informatics at Seoul National University in Korea. I'm very pleased to make a presentation at this conference. I'd like to introduce a study to predict and prevent patient safety events using electronic health record data. The topic of my presentation today is develop and evaluation of electronic health record data-driven predictive models for pressure injuries. Pressure injuries are skin wounds that are most likely to occur in individuals who have limited ability to change positions when seated or lying down. Pressure injuries are one of the most common patient safety events in acute care settings. Pressure injury increase mortality, prolong the hospital stay, and lead to increased medical cost. It's important to identify patients at risk of developing pressure injuries during admission and to implement appropriate intervention to prevent them. Several instruments are available to screen patients at high risk, with the breadth scale being the most widely used. However, the problems of low predictive validity and low reliability of pressure injuries risk assessment tools are continuously raised. Electronic health record data, EHRs, are widely adopted in hospitals, and the patient-related data they contain provide opportunities to improve patient safety and quality of care. If the ability to extract risk factors of pressure injuries from EHR provide data upon which to create a risk profile. If the predictability of the EHR data-driven predictive models for pressure injuries is higher than that of the breadth scale, the model could potentially replace the breadth scale. So we developed 3 different predictive models for pressure injury instance using EHR data and compared their predictive validity performance indicators with the data of the breadth scale used in the study hospital. The study design was a retrospective case control study. We used data of 202 pressure injury patients and 14,705 non-pressure injury patients admitted between January 2015 and May 2016 in a tertiary teaching hospital in Korea. 3 different models were developed and validated in our study: logistic regression, Cox proportional hazard regression, and decision tree model. The predictive validity was measured by sensitivity, specificity, positive predictive value, negative predictive value, and area under the ROC curve. From now on, I will explain in detail how we extracted the data. First, we reviewed literature on the pressure injury to identify features which are related to the occurrence of pressure injury. We identified 95 risk factors from the literature review. Then we explored where we can find these features in the EHR. We identified 8 different data sources. They are initial nurse assessment, clinical observations, nursing activity, patient acuity classification, laboratory test results, medication administration record, surgical information, and nurse progress note. And then 51 features were selected and extracted after excluding features that could not be extracted from the EHR, and those with a frequency of less than 0.1 1%. A feature can be extracted from more than one data sources. For example, pain was documented in 2 different documents, clinical observation sheet and nursing notes. Also, ventilator treatment was documented in 3 different documents, clinical observation sheet, nursing activity sheet, and nursing notes. And as we looked at data recording patterns to extract features from EHR, a feature can be found in more than one data source, documented in various ways and more than one time. When you look at this figure, you can see that the figure oxygen therapy is recorded several times before the onset of the pressure injury and recorded in various documents such as clinical observation record, the nursing activity sheet, and nursing notes. We had to decide at what point in time to extract the data. So to determine when to extract data, we grouped 51 features into 3 groups according to the following criteria: number of recorded type, number of recorded sources, and number of recorded frequency. The results classified into 3 groups according to those criteria are shown in this figure, table. Group 1, such as gender or route of admission, was recorded as one type and recorded only once from one data source. Group 2, such as surgery, was recorded at one type and recorded more than once from one data source. Group 3, such as pain or oxygen therapy, was recorded as several types and recorded more than once from several data sources. And then we use data documented closer to the events within allowed time frame. For group 1 features that were recorded at admission, we extracted data recorded at admission. For group 2 features that were recorded more than once, we extracted data recorded more recently before the pressure injury occurred. For group 3 features that were recorded more than once from several sources, we extracted data recorded most recently before the pressure injury occurred. But if one patient had a feature which was recorded 2 weeks before the pressure injury documents, and that record is most recently data, can we regard that the value of the feature is present in the patients? The question is, how close is closer enough to the event time? So we set the maximum time to allow data extraction. The way we did is like this simple. Let me say that we have 7 patients. We calculate time difference between the time of pressure injury occurrence and the last time the risk factor, in this case pain, was recorded. And then the mean time difference was calculated. The mean time difference was used as the maximum data extraction time allowed. So if a pain was recorded within 1 day before the onset of a pressure injury, there is pain, otherwise no pain. Through this process, the maximum data extraction time allotted for each feature was classified into 1 day, 3 days, and 5 days. The maximum data extraction time allotted of the control group is the same for each features as case group. In this way, the data pre-processed was used to develop the predictive models. 3 prediction models were developed and validated. The dependent variables of logistic regression and decision tree was the occurrence of pressure injury. The dependent variables of Cox proportional hazard regression were the occurrence of a pressure injury and the time to event from admission. We use 70% of data as training data set and the rest as test data set. Independent variables in the model developed or selected by univariate analysis. We consider increasing the feasibility, efficiency, and convenience of the predictive model when choosing independent variables. In univariate analysis, the effective size of a feature with a p-value less than 0.05 were calculated, and the features were listed in order of effect size, and then the graphs are plotted. Considering the number of features to be included in the model and the difference in effect size between the features included up to the point when the slope of the graph changes drastically were selected as features to be included in the model development. This is the result of logistic regression analysis. 11 features were identified to be significant on the development of pressure injuries. Decreased mobility was the most significant feature. This is the result of Cox proportional hazard model. The result is very similar to logistic regression model. In the decision tree analysis, the most significant feature affecting the occurrence of pressure injuries was endotracheal tube. Patients with endotracheal tube and sensory perception impairment was the highest risk of pressure injury development. When we compare three models, logistic regression is the best model. However, all of three models are much better to current pressure injury risk assessment Brad scale is being used in the study hospital. So we have integrated EHI data documented in various data types and sources and multiple times to extract features related to pressure injuries. And we developed predictive models for pressure injuries using EHR data recorded and collected at the point of care. And the predictive model has higher predictive power than the widely used Brad scale. The models developed in this study can be used to develop a clinical decision support system that automatically assesses risk for pressure injuries to aid nurses. It's possible to classify risk groups by calculating the risk of pressure injuries on patients in real time. So we have developed a clinical decision support system that provides evidence-based prevention recommendations that allow nurses to provide patient-tailored nurse interventions. It's currently being implemented in the study hospital, and the clinical effectiveness is being analyzed. So we also developed the clinical decision support system in the same way to prevent fall. The next presentation speaker will introduce the process of the clinical decision support system development in detail. Thank you very much for your attention.